Hi guys, good evening, good evening. Can you all see me? Can you all hear me? Quick feedback. Audible, visible. Good evening, good evening. Alright guys, good evening. Let's get started. Alright, great guys. Chalo. So let's get started. ये जो TND आज का है, this has been concentrated specifically for your INICET as well as your NEET PG. So we have divided the whole TnD into three parts. The part one is going to be general surgery, which includes your trauma and all. Part two is going to be your GIT, and part three is going to be your endocrine and urology. Okay? We can do that, beta. Chal. So we'll start with one question at a time, and then we'll try to build up from there. So the question number one is from trauma. This is something that you will see again and again. Let's try to decode the question that we have at our disposal, right? The question says that I have a patient who's been admitted in the trauma, right, with the history of road traffic accident. On examination, he is going to open his eyes to the painful stimulus, right? Speaks inappropriate words. He's going to speak inappropriate words, and it shows withdrawal of the limbs on stimulation, right? So they're basically asking us to calculate the GCS score. It is not very difficult. How do you calculate GCS score? We all know the GCS is going to be calculated. The GCS is going to be calculated as we call it as E4, V5 and M6, right? E is your eye opening, V is your verbal response, M is your motor response. This is the maximum score that you can give. E is 4, verbal response is 5 and motor is going to be 6, right? Now, quick recap, if a patient has spontaneous eye opening, a score of 4. If he's not opening, if it opens to speech, a score of 3 is given. If still not opening to speech, painful stimulus 2, no opening is 1. Your verbal response to the patient is oriented time, place and person, a score of 5. Patient appears to be confused, a score of 4. If patient is abusing you, that is inappropriate words. So whenever you talk about inappropriate words, in the spelling of inappropriate, you have 3 P's. So remember the score of 3. It's easy way to remember it, right? Then you have incomprehensible sounds where he's making and all that moaning sounds and all, where you're not able to comprehend, a score of 2, no response is 1. Motor, obeys command, moves hands, touches nose, moves away, all that is going to be 6. If he moves to a localized pain, a score of 5. If he withdraws from pain, a score of 4. Abnormal flexion. Abnormal flexion is going to be, which is also called as decorticate rigidity. This is what we call it as the decorticate rigidity. And abdominal extension is decerebrate rigidity. A score of 2. And no response is a score of 1 is given, right? Now, in our question, what do you have? You have a patient is going to have, he's not opening to speech, he's opening to a painful stimulus. So score of E2 is given. Inappropriate words, I still 3 P's are there. So verbal response 3 and motor response when he says that withdraws to the pain. So withdrawal to the pain is there, that is present. That means a score of 4 is there. So E2, V3, M4 is the score. And here the answer is going to be A for Ahmedabad. So nothing spectacular about it. It's a clear-cut sorted out question. GCS scoring, you should be able to know it. On a quick recap, you should be able to get your answers, right? Now, what else they can ask you? Now, the questions that are usually asked in the exam, how much is the maximum GCS? The maximum GCS is going to be 15 by 15. What is the minimum GCS? It is going to be 3 by 15. How much is the normal GCS currently if you are observing and you're into my class, I assume that you are normal. तो अगर आप क्लास सुन पा रहे हो, देख पा रहे हो, लिख पा रहे हो and you're able to comprehend, आपका जीसीएस 15/15 है, उससे कम है तो बेटा जाके सो जाओ, you require rest. ठीक है. Now, what is the risk for coma if the GCS is less than or equal to 8/15? When there's a risk for coma, you have to intubate it. So the indication for intubation is less than or equal to 8/15. Now there's something called a GCS P score. In a GCS P score, we add P. The P stands for pupillary assessment score. P stands for pupillary assessment. A pupillary assessment score. So when I say pupillary assessment score, we say both the pupils are reactive to light, right? If bilateral pupil reactive to light, a score of 0 is given. If only single pupil reactive to light, a score of 1. If bilateral pupil non-reactive to light, if the bilateral pupil non-reactive to light, a score of -2 is given. A score of -2, right? So if one pupil is reacting, the other is not reacting, score of -1. If both the pupils are not reacting, a score of -2. If both the pupils are reacting, it is 0. So even if you add the GCSP criteria, no, this total score remains the same. So the maximum GCSP score, when I say E4, V5, M6, so pupillary maximum is 0. So I can still say the maximum score here still remains as 15/15, right? So even if I add the pupillary assessment, the scoring is not going to change much, and that's your carry home message. Now, based upon the head injury classification, this was our previous exam question, right? Based upon the head injury classification, how do you categorize? Are you looking at a minor head injury, a mild, moderate, or severe head injury? Now, to call it as a minor head injury, the GCS of the patient should be 15/15 with no loss of consciousness. Mild GCS can be 14 or 15 with history of loss of consciousness. If a GCS is between 9 to 13, then a moderate, and if it is GCS of less than or equal to 8, it is considered to be severe. So this is based upon the GCS criteria to call the patient to have a minor, mild, moderate, or severe head injury, right? So these are all the important points with respect to GCS that you should be knowing and aware of. If these concepts are clear, very unlikely that you will go wrong on a GCS scoring system question, because majority of the times, every single exam when they ask you in trauma and head injury, their favorite question is to ask something from GCS, and I hope you're comprehensively been briefed about it. So far, so good. Any problem? Chal. Now, so question number 1, A for Ahmedabad is the answer. Now, question number 2. I have a patient who has undergone surgery for breast cancer. 6 months later, she presented with a lesion depicted below, right? Now the diagnosis would be, now you can see here, it is a clear cut where you can see there's an extensive scarring which is going beyond the skin markings, right? Beyond the skin markings. So if you have a patient which have a scar which goes beyond the skin marking, the answer is going to be keloids. Thrombophlebitis is basically inflammation of the subcutaneous veins, which is going to not present to as a scar-like formation. Hemangioma will have increased vascularity. Neurofibromas will have skin lesions which are going to be widely distributed and they're evenly distributed. So this is a clear-cut case of keloids. Usually, our doubt is to differentiate between the hypertrophic scar and the keloid, and I've given you a small table to differentiate that. Now, when you look at the difference between a hypertrophic scar and a keloid, when I say hypertrophic scar, it is going to be limited to wound site. It is going to be limited to that of the wound site. Keloids, on the other hand, it is going to involve normal surrounding skin. It involves the normal surrounding skin as well. Etiology of the hypertrophic scar is believed to be because of excessive amount of fibroblast, whereas keloids, it is because of defective fibroblast. It is defective fibroblast. The hypertrophic scar forms within the 6 months, whereas the keloids continue to grow even beyond 6 months. Hypertrophic scars, when you look at their presentation, there is no, as such, I can say that there is a predominant sex determination. They're equally seen in males as well as females. But you see here, keloids are more common in females when compared to males. See, hypertrophic scars and keloids usually form in the area Preeti, we have GIT discussion on the second day of our TnD discussion. This is day 1. Total 3 TnDs are there. Right. So, when we talk about sites, it can be found anywhere. The most common site for keloids is going to be sternum. In both the component, you will see the type 3 collagen will be more when compared to type 1 collagen. The ratio here is 6:1 and here it is 20:1. There is no pain, there is no itching, there is no family history for hypertrophic scar. The pain may or may not be there, itching is usually there and family history is present. Remember in hypertrophic scar, see, both hypertrophic and keloids are basically cosmetic deformities. So you don't need to do anything specifically, but if a patient demands, for your hypertrophic scars, you can do a pressure dressing, you can do an intralesional steroid, that is triamcinolone, or you can do a revision excision. Whereas in the context of your keloids, if you do surgery, there is a very high chance of recurrence. So here we do pressure dressing, use an Nd:YAG laser, topical methotrexate, topical vitamin C or vitamin A. You can also give intralesional steroids in the keloids as well. So that's the difference between hypertrophic scars and keloids, and this is your exam question. This table is very, very important. So do a quick recap whenever you have time to look across it. The most important is on the image basis. If it is limited to that of the wound site, it is hypertrophic scar. If it involves the normal surrounding skin along with the wound site, it is going to be keloid. That's the carry home message that you need to hear. So here the answer is going to be A for Ahmedabad. That is going to be keloids. Going to question number 3. Now, this is something which has been asked repeatedly again and again and again. The question says that let's say an intern was asked to calculate the QSOFA score. Which of the following factors can be used to determine the score? So when I say QSOFA, I hope everybody knows it. QSOFA stands for Quick Sequential Organ Failure Assessment Score. The 3 components are there: systolic blood pressure, GCS, and respiratory rate. So here, what are the components to be decided here? So you have the systolic blood pressure. Systolic blood pressure is here. Then you have GCS and the respiratory rate. So when you look at, we don't have the pulse rate, so this is wrong. Temperature is again not a finding here, so it is also wrong. Yes, respiratory rate, systolic blood pressure, GCS, all 3 of them are sitting properly here. So answer here is going to be C for Calcutta. So QSOFA is Quick Sequential Organ Failure Assessment Score. If there are more than or equal to 2 components of positive, it is associated with poor outcome. Now, usually, earlier we used to have something called as SIRS, which is Systemic Inflammatory Response Syndrome. There are 4 criteria, that is temperature less than 36 or more than 30 degrees, WBC count of less than 4,000 or more than 12,000, respiratory rate of more than 20, heart rate of more than 90. But here you can see respiratory rate in SIRS is 20, whereas the respiratory rate in your QSOFA is 22 cycles per minute. That's the difference. So difference between the QSOFA and SIRS is important. So here the answer is going to be C for Calcutta. Question number 4. Now, this is something that you guys need to be absolutely clear on. The image-based question itself is important. Can you tell me what is this technique in which the skin is being done? Would you like to call it as pie crusting, or would you like to call it as the skin meshing? So what do you think this technique is? Is it pie crusting or skin meshing? A quick feedback on the chat box. The chat box needs to buzz. Come on, guys. Batao. Is it going to be meshing or is it going to be pie crusting? A quick feedback. क्या बोलते हो? Pie crusting है या फिर skin meshing है? Pie crusting, skin meshing. Pie crusting, skin meshing. Beta, both pie crusting and skin meshing can be done for split thickness skin graft. So you cannot say it is a split thickness skin graft. I want you to tell me whether it is a pie crusting technique or whether it is a skin meshing technique. Quick feedback. Preeti, you are absolutely correct, beta. Anyone else? Anyone takers? More takers? Koi nahi hai. So let's see. This is what type. When you look at the question says that what type of dressing is used to cover the post-burn wounds. So I would see when you talk about this, it is a skin graft. So obviously because there's skin graft here, I can rule out VAC. This is not VAC. This is not normal sumac dressing. The difference is whether it's going to be split or a full thickness. Whenever you have a large surface area, we always prefer a split thickness skin grafting. There is no point for guessing at all. So answer here is going to be A for Ahmedabad, right? So the question is very simple. All of you are giving me right answers. I'm pretty happy about it. So when you talk about these skin grafts per se, there are two varieties, split thickness and a full thickness skin grafting. The split is also called as Thiersch. The full is also called as Wolfie's graft. In the split thickness, what is the composition? You have the epidermis. You have the epidermis of the skin. Along with that, there is part of dermis, not the entire dermis is taken. Wolfie's is going to be an entire epidermis of the skin along with the entire dermis of the skin. So you have taken both epidermis and dermis together. Hence, it is called as a full thickness skin grafting. What is the most common donor site? For Thiersch, it is going to be the lateral aspect of the thigh. It is the lateral aspect of thigh. Wolfie's, which is a full thickness, it is usually taken behind the ear, retroauricular. I hope everybody knows the reason, because split thickness skin grafting, it regrows back. There is no permanent defect. There is no scar at all. So you can do regrafting also. In a full thickness skin graft, when you take the graft from the donor site, that donor site will have a scar and you cannot take a repeat graft. Hence, it is not possible to take a bigger graft from there. How do you know you have taken a partial thickness of Thiersch graft? You see presence of punctate hemorrhage from the site of the donor. But whereas if you expose the subcutaneous fat, if the subcutaneous fat is exposed, it's a full thickness skin grafting. Defect size in partial, it could be any size. Full thickness, we usually take small grafts. Repeat from the same donor site can be performed because it regrows back. This is a permanent defect in full thickness, you cannot do it. Graft survival is good in partial thickness because it requires less amount of nutrition. More the size of the graft or more the tissue in the graft, more is the oxygen demand, more is the nutrition demand, and if the supply is not there, it is going to die off. So the graft survival is going to be poor. Now, what is a graft contracture? There are two contractures, primary and secondary. What is primary contracture? You take the graft from the donor side, that contracts immediately. That immediate contraction is what we call it as primary. On the other hand, if you put it on the recipient bed and then it starts to crumple slowly, this is called as secondary contraction, right? So immediate is primary. After applying on the recipient side, it is called as secondary. In a partial thickness, it is secondary more when compared to primary. Here it is primary more when compared to secondary. Wherever you have more secondary contraction, you have an ugly looking graft. So cosmetic outcome here is going to be poor and here it is going to be good. Here it is going to be good. Now, these are the images. Now, there is a spotter for you. What is this image number 1? Now, is it a pie crusting or skin meshing? Quick feedback. Pie crusting है कि skin meshing है? फटाफट बोलने का क्या है भैया? What is this? क्या बोलोगे इसको? Pie crusting बोलोगे या फिर skin meshing बोलोगे? आंसर है इसको आप बोलोगे pie crusting, है ना? The advantage of doing a pie crusting is, क्यों करते हैं pie crusting? It is to prevent. The objective of doing the pie crusting, it is to prevent. What are you trying to prevent? You are trying to prevent hematoma and seroma collection, not formation. It also increases the surface area of graft from anywhere between 1.5 to 6 times. So hence it is going to be useful technique. Fair technique number 2. This we have just discussed it. This is what we call it as the skin meshing. This is what we call it as the skin meshing. इसको skin meshing बोलते हैं, इसको आप pie crusting बोलते हैं. दोनों का difference देख लो. They are like stab wounds here. It is like a complete mesh, equidistant, equi holes. That there's more amount of gap when compared to skin. It is meshing. More skin and less gaps. It is crusting. Now, how do you achieve this? ये जो machine है, this is called as mesher. We call it as the skin mesher. You put the skin, you roll it, and it is now going to go through it and it is going to provide into mesh. This you can see, you're taking the partial thickness skin graft, you'll be able to take it exactly like this. Okay? Now this is what we call it as an electric dermatome. This is for partial thickness skin graft. Like in this is what we call it as the Humbee's knife. So easier way of doing is going to be an electric dermatome. Easier way of removing is going to be the same thing you do as an electric dermatome. Humbee's knife, on the other hand, is going to be what we use it as a rude method. So these are the various images. See, skin grafting mein, they cannot go up questions beyond this that they have put across here. So that's a question number 4. Let's go to question number 5. Identify the condition given or the grade that they're asking. They're asking to grade the image given below. So this is at the sacral site, right? And there's a wound that is present here. So it is going to be a pressure wound. Now, if the underlying muscle is exposed, what is the grade of this condition, right? So when you look across here, what are the grades? So this is for pressure sore. You can call it as the bed sore. You can call it as the pressure sore. You can call it as the pressure ulcer. This is also called as the decubitus ulcer. All these are the synonyms that you can have. The bed sore, the pressure ulcer, the decubitus ulcer, everything is the same. Now, when you say the grade 1, there will be presence of non-blanching erythema, grade 2 partial thickness skin loss, grade 3 full thickness, grade 4 involvement of underlying structure. As you can see, the underlying structure is involved. So the answer is very clear. It is going to be grade 4. Right? Now, usually the question that they ask you is how do you manage this, right? There's another grade which is called as unstageable. If an ulcer is covered with slough and necrosis, the true depth of the ulcer cannot be assessed. So I cannot comment whether it is a grade 3 or a grade 4 ulcer. I cannot comment whether it is a grade 3 or a grade 4 ulcer, right? It's a grade 3 or a grade 4 ulcer. Now, when you have grade 1 and grade 2, you go with conservative management where you have water or an air bed, frequent change in position. When you say frequent change of position, if a patient is bedridden, every second hourly you have to change the position. If a patient is wheelchair bound, change the position in every 10 minutes. Skin care is important. If there is a grade 3, grade 4 unstageable, the first thing is going to be cleaning and debridement, and then you have to put the dressing. Normally, it was earlier called as VAC, that is vacuum assisted closure. Now that term is not used. We use it negative pressure wound closure system. The pressure applied, that was a previous exam question. The pressure applied in negative pressure wound closure system is minus 125 millimeters of mercury. It is going to be an intermittent pressure. It increases it promotes the granulation tissue, right? Also, it decreases all the collection and secretions which are present. And the last one is to continue the conservative management protocol, right? So this is how you manage your decubitus ulcer. If they are going to ask you what is the most common site for pressure ulcer, it is going to be ischium, followed by your greater trochanter, followed by that is going to be sacrum, right? Chalo, question number 6. We have just discussed that, right? What is the question? What is the ideal pressure setting for vacuum assisted closure? This was also a previous exam question. It is going to be minus 125 millimeters of mercury. This is the only option in minus. It's a very easy answer to give it. It is minus 125 millimeters of mercury applied on intermittent basis. It is no longer called as VAC. VAC is an old term. Now it is called as negative pressure. This is called as the negative pressure wound closure system. This is called as the negative pressure wound closure system, right? So VAC is an obsolete term. Now we call it as negative pressure wound closure system. And this is the image of NPWCS, negative pressure wound closure system. This is how it is going to look like. So there is this foam which is present. There's a sealing where you can see the plastic wrap is there to seal it. Then there is a tubing that connects to this machine which creates a negative suction. And this whole setup is what we call it as the VAC setup, right? It is a negative pressure wound closure system. Now, question number 7, how does a graft get the nutrition on day 3? Now, when you talk about the phases of skin grafting, now, when you give, there is a plasma imbibition phase, then there is an inosculation phase, and there is a neovascularization phase. Now, in the plasma imbibition phase, it is going to last until 48 hours, where graft gets nutrition via diffusion. The graft is going to get the nutrition via diffusion. It is going to get via diffusion, right? So until, okay, wait. One second, guys. Okay, so small correction here. We'll go through all the phases of skin grafting. One second, guys. Okay. Now, see the two confusional points that I wanted to clear. Yes, that is also important. Guys, do not try to text me directly. You can do it on the chat box. Yeah, please do it on the chat box. Sure. Right. So when you talk about the plasma imbibition phase, so we have three phases. I'll just create all the phases of the skin grafting. The first phase of the skin grafting is what we call it as the plasma circulation. It is called as the plasma circulation, or also refers to as the serum imbibition, or also referred to as the serum imbibition. That is the first phase, which is going to last for approximately 48 hours. Here, the graft gets its nutrition via diffusion, as we have discussed it. Then there is phase of revascularization. That is going to be revascularization, right? So in the phase of revascularization, it starts after 48 to 72 hours. It starts after 48 to 72 hours, and it is going to last between 3 to 5 days. So from day 3 to day 5 is the phase of revascularization. And the last one is going to be organization. The last one is what we call it as the organization, where it will cause an established arterial, venous, and lymphatic drainage. And this occurs after day 5. It occurs after day 5. Now the question is, how does the graft gets its nutrition on day 3? So usually we can say by day 3 it gets by both plasma imbibition as well as revascularization. Ideally, revascularization is still occurring between 48 to 72 hours. That is day 2 to day 3. So on day 3 it is contributed by both of them. Single best answer is going to be the plasma imbibition phase, right? The single best answer is going to be the plasma imbibition phase, which is going to contribute to that, right? So remember, on day 3 it is going to be the plasma imbibition phase. Okay, question number 8. Now this is a very important question. You can put it like a double Q mark. The question says, which of the following is a complication of total parenteral nutrition, which has been given in a sepsis patient in ICU? Remember, the overall most common complication of TPN is excessive feeding, and that will result in hyperglycemia. That is going to be hyperglycemia. So this is the single best answer that you should get in terms of total parenteral nutrition. See, I can go on and on about TPN, but some couple of important things that you should remember with respect to your total parenteral nutrition. So when you talk about the TPN in general, first is the composition of the total parenteral nutrition. The composition of the total parenteral nutrition. Let's do a quick recap on that. The first and the foremost thing that you will see in the total parenteral nutrition is going to be carbohydrates. Now, carbohydrate accounts for 40 to 50% of the total volume of the TPN, and they provide you with 3.5 kilocalories per gram. This is the energy release of carbohydrate. Then you have the fat, or also commonly referred to as the lipids. They account for 30 to 40% of the total volume, and they release 9 kilocalories per gram. Energy releases 9 kilocalories per gram. Then you have the proteins. The proteins account for 10 to 20%, and they have 4 kilocalories per gram. They are going to release an energy of 4 kilocalories per gram, right? Then you have the vitamins and the trace elements. They are negligible in volume. Vitamins and trace elements are negligible in volume. So this is the first thing that you should know with respect to total parenteral nutrition. Now, when you talk about the overall complication, that is important. So when you talk about the complications associated with total parenteral nutrition can be classified into two categories. One we call it as the line related, another one is feeding related. So we will differentiate them on the basis of line related complications, and then you have feeding related complications. So we have two sets of complications. One is going to be line related, another one is going to be feeding related complications. So when I say line related complications, in the line related complications, the most important one, while inserting the line itself, it can result in pneumothorax. It can result in air embolism. Pneumothorax can result in air embolism. It can be associated with the thoracic duct injury. It will be associated with the thoracic duct injury. Can result in cardiac tamponade. All these can occur during the insertion. Post insertion, it can result in line sepsis. It can result in line sepsis and venous thrombosis. If they ask you what is the most common line related complication, the most common, if they ask you the most common line related complication is going to be line sepsis. When we talk about feeding related, in the feeding related, you have either overfeeding or it is going to be nutritional deficiency. So either it can result in refeeding syndrome, it can result in refeeding syndrome, or it can result in overfeeding. Always overfeeding is more common when compared to refeeding syndrome. So overfeeding, it will be associated with hyperglycemia. And remember, feeding related complications are more common when compared to line related complications, right? Now, when I say refeeding syndrome, in the refeeding syndrome, as you suddenly start giving the total parenteral nutrition, there's sudden surge of sugar. When there is excessive amount of sugar that is going to be taken across, there will be excessive release of insulin. That excessive release of insulin will now cause, number one, hypoglycemia. So the sugar will drop suddenly. This decrease in sugar will also cause decrease in calcium. It will be associated decrease in magnesium as well as phosphate. This is what we call it as the refeeding syndrome. This is what we call it as the refeeding syndrome, right? So these are the important points with respect to your total parenteral nutrition and its complication. Do have a look at it. Very, very important. So here the answer is going to be B for Bombay, that is hyperglycemia. Question number 9. What is the appropriate management of a patient presented with a constant chest pain and radiograph as a Stanford A variety? Now, normally when you talk about the Stanford, you should know that is associated with aortic dissection is already given. We don't follow Stanford, we now follow DeBakey's classification. Let's quickly do a recap on DeBakey's classification of aortic dissection. Now, if the site of the dissection starts from the ascending thoracic aorta and the dissection goes all the way to the aortic bifurcation, it is type 1 DeBakey's. If it starts with ascending thoracic aorta, limits to ascending, it is type 2. If it starts at descending thoracic aorta, goes all the way to aortic bifurcation, this is called as type 3. Based upon where the dissection starts, it is what we call it as Stanford A. This is what we call it as the Stanford A. And if it is at the descending thoracic aorta, this is what we call it as Stanford B. This is what we call it as the Stanford B classification. So the whole objective is Stanford only took into consideration the site of dissection, not the extent. DBK took the site as well as the extent as well. So when you talk about in DBK's type 1, the start of the dissection is going to be at the ascending thoracic aorta and goes all the way to the level of aortic bifurcation. In type 2, it starts at ascending thoracic aorta, limits to ascending thoracic aorta. Type 3, descending thoracic aorta, they start and it goes all the way to that of the aortic bifurcation. It goes all the way to the level of aortic bifurcation. That is your type 1, type 2 and type 3. Now, the first line of management is to start the patient on beta blockers, that is esmolol. That's your cardioselective beta blocker. Now, if the ascending thoracic aorta is there, then you have to go with grafting. So here, you have to go at Dacron graft repair. Here, we usually prefer Dacron graft repair. In type 3 or Stanford B, if the patient is stable, then observe. If the patient is unstable, then here also Dacron graft repair. Then go ahead with Dacron graft repair. So this is on the basis of aortic dissection. So in Stanford A, that is DBK, Stanford A is both DBK type 1 and DBK type 2. If you talk about it, they're asking appropriate management, right? So if they ask you what is the first line management, the answer is going to beta blocker. So beta blocker becomes the first line management, right? The first line management is going to be this, right? Whereas they're asking appropriate, then you have to be Dacron graft repair. So answer here is going to be A for Ahmedabad. That is going to be surgical management. That is going to be Dacron graft repair. Going to Dacron graft repair. Chalo. Going to question number 10. Now, in the question number 10, what do you have? I have a patient with a stab wound to the abdomen. On the examination, there was hypotension with abdominal wall tenderness, right? Now, hypotension indicates there is hemodynamic instability. Abdominal wall tenderness indicates there is peritonitis, right? Obviously, is given the next line the same. This suggests peritonitis. What is the next step in the management? For all stab wounds, hemodynamic instability is an indication for exploratory laparotomy. So question number 10. I'm not going to wait for anything. Take the patient directly for surgery. It is going to be exploration. There is no if, there is no but. And hence we have this protocol. We say if a patient is presented with a gunshot wound, always take the patient for exploration. There is no if, there is no but. If the patient comes with stab wound, we see whether the patient is having the weapon of stab in situ or not in situ. If the weapon of stab is in situ, if it is present, so do not remove the weapon. We see whether the patient is stable, unstable, unstable. Do not remove the weapon. Go ahead with CECT abdomen. Look for organ injury. If it is present, laparotomy. If there is no organ injury, go for wound exploration. Look for peritoneal breach. Presence of peritoneal breach, go with laparotomy. No peritoneal breach, wound closure has to be performed. Nothing more, nothing less. Right. On the other hand, if the weapon of stab is not in situ, we see whether the patient is stable or unstable. If the patient is stable, you follow the same protocol. That is, take the patient for CCT abdomen and then continue. Unstable, take for exploratory laparotomy. Why not fast? But a fast is to be performed in blunt trauma abdomen. Every patient of blunt trauma abdomen, before you go in, irrespective of stable, unstable, the first step is fast. For a penetrating injuries, if the patient is unstable, directly going to go for exploratory laparotomy. Do not waste time. I've been telling this in my lecture. I've been screening on the top of my voice. Blunt trauma abdomen, you need to do. For a blunt trauma abdomen, you have to perform For a blunt trauma abdomen, I told you that you have to perform fast. Whereas in penetrating trauma abdomen, if the patient is unstable, take the patient direct for exploratory laparotomy. That is the end of discussion. There is no if, there is no but. Okay. Chalo, going to question number 11. Now, what do you have in question number 11? I have a 2-year-old child brought to the emergency department in an unconscious state with no history of trauma. What is the first step in emergency management? See, ideally you should secure the IV line. At the same time, also secure the airway. I will not directly administer the glucose unless I don't know what is the status, so I have to do an RBS. Secure the airway and assess the breathing makes sense. No need for chest compression, no need for lumbar puncture. Of all the given options, B is going to be best. Secure the airway and assess for breathing if the patient is because in unconscious status there could be a tongue fall, and tongue fall can cause absolute apnea. So if the patient is unconscious or 2 years, whereas irrespective, airway has to be given preference. Question number 12. What do you have in question number 12? There is a linear incision on the limbs on the burn patient. Very good. These incisions are along the medial and the lateral aspect of the limb. Okay. Which of the following statement is true regarding this procedure? Can anybody tell me what procedure are we talking about? क्या है ये procedure? What is this procedure called as? What is this procedure that we're talking about? We are talking about escherotomy. Now, this is basically to prevent compartment syndrome due to a wound contracture, especially if there is a circumferential burns. Escherotomy is a procedure where you give releasing incisions. I hope everybody knows the mnemonic for the escherotomy. The mnemonic is what we call it as LAID, right? L stands for the incision should be linear. The incision should be linear. Very good, beta. Okay. Can you tell me what is an absolute indication for escherotomy? What is the absolute indication for escherotomy? What is the absolute indication for escherotomy? Quick feeding. Absolute indication, circumferential burns. Please do not forget it. Escherotomy ka absolute indication is circumferential burns. A, the incision should be in the axial plane. It should be in the axial plane. I stands for, it should, see, whenever you're doing an escherotomy, you have burnt area in the normal skin. Tell me, in which area would you like to incise it? Would you like to incise on the area where it is burn is there, or the area where you have normal skin? Quick feedback. Where would you like to put the incision? Would you like to put the incision onto the normal skin or onto the burnt area? Normal skin में लगाओगे कि burnt area में लगाओगे? फटाफट बताओ. Now here incision in normal skin area. And D stands for, it is going to be depth of subcutaneous. So down to subcutaneous fat. So incision should be deepened only until the subcutaneous fat. Somebody has given me right answer. Yes. Absolutely correct, beta. Sandeep, you are correct. It is going to be in the normal skin area. So this procedure is called as escherotomy. I have depicted it here. So as you can see, we have performed the escherotomy not on the burnt area but on the normal skin areas, and these are the planes. The dotted lines are the lines in which you have to perform escherotomy. The hard lines are the areas where you have to leave it. In the medial aspect, you have to leave the ulnar, lateral radial artery and the cephalic vein area. In the joints, you have to leave it because of the long saphenous vein and the posterior tibial on the medial side. Lateral is common peroneal vein and the short saphenous and the sural nerve on the lateral side. Dotted areas are the lines of escherotomy that you have to perform. Escherotomy prevents the compartment syndrome. Now the question is, which of the following statement is true? You are looking for a true statement in this particular question. So which among the following is a true statement? This is used for circumferential burns to relieve pressure. It is not to relieve pressure, it is to prevent the compartment syndrome. So I would not agree with the first one. This shows excision and skin grafting. It is also wrong. Escherotomy is not excision and skin grafting. The incisions are made to avoid visible blood vessels. No. The incisions are cosmetic and non-clinically significant. No. So if you look at all four, it is relatively wrong. But when you say this is used for circumferential burns to relieve pressure secondary to compartment syndrome, can be a right option. So among all the four options, 12A is correct. 12A is correct, right? So it is used for circumferential burns to relieve pressure, secondary to prevent compartment syndrome. It is to prevent compartment syndrome. I hope everybody knows the pressure required to create compartment syndrome. It should be more than 30 millimeters of mercury. The pressure required to call it as compartment syndrome, it should be more than 30 millimeters of mercury. It should be 30 millimeters of mercury. So answer here is going to be A for Ahmedabad. Now you have question number 13. What do you have in question number 13? A patient with a circumferential full thickness burn over the right lower limb. Okay. Developing progressive pain, pallor, and decreased distal pulse. So this is classical for compartment syndrome. What is the most appropriate next step? We just saw it. The most appropriate next step: elevate the limb and ice pack, IV antibiotics, escherotomy is what I'm looking for to relieve vascular compromise. So answer here is going to be C for Calcutta. There is no if, there is no but. We have already discussed it. Question number 13, answer is C for Calcutta. Question number 14. What do you have in question number 14? This is your favorite question for examiner. I don't know, your NEET PG people and your INI are in love with vascular disorders, especially the varicose vein, and SEEP classification is their favorite topic. Here the patient presents to you with dilated tortuous superficial vein consistent with varicose vein in his lower limb. Which of the following statement is correct regarding this condition? Right now, number one, let's look at the statement number one. Varicose vein are only cosmetic, no, and have no the spectrum of complications. It can start from skin changes all the way to ulceration. Statement one is wrong. Varicose vein can lead to eczema as well as pigmentation. Yes, it is because of lipodermatosclerosis. It is correct. Sclerotherapy is treatment of choice for all cases. No, it is only for size less than 3 millimeters in diameter can be done for sclerotherapy. More than that, you have to go with surgical excision. So sclerotherapy is not for all cases. So the point all cases is going to be wrong. Surgery is contraindicated in symptomatic beta. Surgery is the only main stem for symptomatic. So answer here is going to be B for Bombay. There is no if and but in that. Such an easy question. Now in the SEEP classification, they'll ask you this. What is C1? It is telangiectasia. What is telangiectasia? Size of the vein is less than 1 millimeter in diameter. Reticular vein is 1 to 3 millimeters in diameter. Varicose vein is going to be more than 3 millimeters in diameter. C2R is recurrent varicose vein. C3 is going to be edema. 4A is going to be pigmentation. The pigmentation is because of lipodermatosclerosis. So pigmentation leads to lipodermatosclerosis. Pigmentation is secondary to what? The RBCs get broken down to heme and globin. Globin gets absorbed. Heme goes into forms the hemosiderin. Hemosiderin combines with melanin, and that condition is called as hemosiderosis. Hemosiderosis results in pigmentation, and that pigmentation will now result in lipodermatosclerosis. That is, lipo is what? Fat. Dermatos, skin. Sclerosis is what? Fibrosis. It will result in fibrotic limb, which will result in champagne leg appearance. Also, that is C4B. Coronophlebectatica is also called as malleolar flare, where you get all the veins dilated around the level of ankle. C5 is healed venous ulcer. C6 is active. Based upon the etiology, EC is congenital, P is primary etiology, S is secondary etiology. Anatomy, involvement of superficial venous system, AD is deep venous system, AP is perforator. Secondary to pathophysiology, if it is because of obstruction, it is PO, and if it is because of reflux of blood flow, it is called as PR in general. So these are the images that you need to remember. Image number one, this is what we call it as telangiectasia. In telangiectasia, you can see the thin thread-like veins which are present. These are these thin thread-like veins which are present. Then you have reticular veins. The difference between the telangiectasia and reticular veins, telangiectasia you can't palpate, reticular veins you can palpate, right? Then you have the varicose vein. This is the image for varicose vein. This is the image for pigmentation. This is the image for lipodermatosclerosis. Now, when you look at the limb, it appears like inverted champagne bottle appearance. It occurs at the level of ankle. It looks like a bottle of the champagne which is put inverted. So, it's called as the inverted champagne bottle appearance. It is the inverted champagne bottle appearance. And the last one is going to be venous ulcer. How do you know it is a venous ulcer? Everybody knows it. Number one, it is present at the level of medial malleus. Number two, it is going to be shallow ulcer. It is going to have sloping edge. And it is going to have pale, scanty, unhealthy, unhealthy granulation tissue. It is the pale, scanty, unhealthy granulation tissue are the findings that you can see for venous ulcer. So this is in the context of varicose veins. Going to question number 15. Now, in question number 15, what do you have? Question number 15 says an intern placed an intercostal drain in the patient. Which of the following steps is going to be incorrect? Now, when you talk about the intercostal drain, let's quickly talk about their objective. Let's say this is the lateral surface. Now, let's say this is the lateral side of the chest that you have, right? Now, I can divide them into, this is going to be the mid-axillary line. This is going to be the anterior axillary line. This is going to be the posterior axillary line, right? So this is on the lateral side that you have. This is going to be the anterior axillary line. This is the mid axillary line. This is the posterior axillary line, right? Next, you see that you have the ribs which are going to be present, right? So let's say these are the representation of the ribs that you have, right? So let's say this is another one rib. There's another rib which is present here. This is present here. So these are the ribs which are present on the lateral side, right? So these are the ribs which are going to be present across here. Now, when you look at this, usually when you are going to place the ICD, if I say this is the second rib, this is the third rib, this is the fourth rib, this is the fifth rib, this is the sixth, this is seventh, and this is the eighth rib, right? These are the numbering that you're given for ribs. Now, between, that is the fifth intercostal space, that is between the fifth and the sixth rib, this area is what we call it as the fifth intercostal space. This entire area, or I can simply say this entire area is what we call it as the fifth intercostal space. So the first thing, the ICD should be placed in the fifth intercostal space. Now see, anteriorly there will be a muscle that is going to be present, that is your pectoralis major muscle, right? So the muscle that is going to be present anteriorly is your pectoralis major, posteriorly there will be latissimus dorsi, and this triangular area which is formed here, this is what we call it as the safety triangle. This is what we call it as the safety triangle. I would like to place the ICD in the fifth intercostal space in the mid-axillary line within this safety triangle. Another very important thing is the neurovascular bundle that is present will always be running on the inferior surface of the rib. The neurovascular bundle will be running on the inferior surface of the rib. So obviously, whenever I'm trying to put the ICD, I will always try to go from the superior surface of the rib. If I try to go from the inferior surface, so if there are two ribs here, when you're inserting, I'll try to hug the superior surface. I'll try to hug the superior surface, not the inferior surface. If I try to go through the inferior, I will hit the intercostal vessel, it will bleed. So always hug the superior surface and go, right? And place it. These are the steps for ICD placement. Okay? Now, let's see here. They're asking for incorrect step. Identify the fifth intercostal space anterior to mid-axillary line to place the tube is correct. Insert the tube along the upper border of the lower rib. This is also correct. Direct the tube posteriorly to prevent injury. Now, whenever you're trying to push the tube, you're not trying to go anterior posterior, you're trying to go bang on and slightly up. Okay? So this is wrong. Incised and digitally explode. So basically what you do, put an incision and then you insert the finger to make this space out. Okay? So digital insertion is being provided. Okay? It becomes a fairly a little bit more technical, but we know that you're not trying to go posteriorly. You'll try always where the space is present and your purpose is very clear. So you go bang on. You don't go anterior posterior, you go bang on in the same line and then you insert the tube. Okay? So either it is going to be straight or slightly placed anterior, but never posterior. So posterior is absolutely wrong. So answer here is going to be C for Calcutta. It is going to be C for Calcutta. right? Now, if they ask you what are the boundaries of the safety triangle, safety triangle is present in the fifth intercostal space. It is in the fifth intercostal space of mid-axillary line. So the anterior, posterior and inferior. Anterior is formed by the pectoralis major muscle. Posterior is formed by the latissimus dorsi muscle. And inferior is formed by the sixth rib. Inferior is formed by the sixth rib. Okay. So that's your C for Calcutta. Question number 16. In question number 16, what do you have? We are talking about a patient with the blast injury. Which of the following organs is least vulnerable for the blast waves? Now you see, blast waves are shock waves and they amplify in hollow spaces where you have air. Now GI tract, does it consist of air or not? The answer is yes, it consists of air. Lungs consist of maximum amount of air. Liver has no air. And obviously the tympanic membrane, the middle ear consists of air. Wherever you have air, the shock waves are going to amplify. The injury is going to be more significant. So obviously GI tract injuries will occur, lungs will occur, eardrum will occur. There is no air in liver. So liver injury will not occur. So answer here is C for Calcutta. All solid organs are shock proof. As simple as that. If air is present, it amplifies it. Okay? If they ask you what is the most common organ injury, the answer is going to be tympanic membrane. If they ask you most severe, the one which is associated maximum amount of air will have the most severe one, that is going to be lungs. If they want to make your life a little bit more difficult, they'll ask you about the classification of the blast. There's a primary blast, there's a secondary blast, there's a tertiary blast, there's a quaternary blast, and there's a quinary blast, right? Now, what is a primary blast? When the bomb is going to explode, it is going to create that shock waves. The injury due to shock wave is called as a primary blast injury, which is called as an overpressure. These are the sites where you have tympanic membrane, you have lung injuries, and the intestinal injuries can occur. Secondary is when the bomb is going to blast. First the shock waves will come, then whatever is there in the bomb, it could be those pellets are there, sharpnels are there, they'll come and stick onto you. And that fragmented injury, where all penetrating injuries are secondary. What is tertiary? Now, as that blast is going to hit, you're going to fly and fall. And then when you fall, it creates a blunt trauma. So blunt force due to fall can result in crush injuries and blunt force injuries. That is going to be tertiary. Quaternary is going to be all other miscellaneous one, example like burns and inhalation. Quinary is the effect of the device additions that you have, right? Radiation sickness, depends upon what type of bomb has been used, that is called as quinary blast. So these are the classification, their components and the examples, all of them are important. Just give a quick recap on the same as well. So here the answer is going to be C for Calcutta. Question number 17. In the question number 17, which of the following statement is false regarding the deep vein thrombosis, right? Now, DVT clinical assessment is going to be unreliable. See, clinical assessment is not always consistent with DVT. It always gives you probably, if and but in that context. We're looking for a false statement. So, clinical assessment is unreliable is true. It is mostly unilateral, not bilateral. So, this is a false statement. Most common clinical presentation is pain and tenderness in the calf. That is absolutely correct. Some cases may be directly present. Yeah, the most feared complication of DVT is pulmonary embolism. They can land up directly with pulmonary embolism and present to you. So answer here is going to be B for Bombay. It is usually unilateral, not bilateral. Now, the specific conditions which we are interested in, number one is going to be HIT syndrome, that is heparin-induced thrombocytopenia. As we all know, the investigational choice for DVT is duplex scan, the treatment is anticoagulation. Usually, you can start with heparin. Problem is, there's some people have heparin sensitivity resulting in your heparin-induced thrombocytopenia, where the patient will start developing bleeding manifestation after starting heparin. What do you do in that? Now, if a patient develops bleeding manifestation, stop heparin immediately, because the patient will start developing bleeding gums, epistaxis, there's decrease in platelets. So what do? Do you immediately switch you're going to immediately switch to novel agents. The novel agents that we have are going to be fondaparinux, rivaroxaban, apixaban, and bivalirudin. Remember, fondaparinux, rivaroxaban, apixaban is factor 10A inhibitors. Bivalirudin is your direct thrombin inhibitor. These are direct thrombin inhibitor that you have. No, see, you need to understand that none of the clinical examinations in DVT are endorsed. Okay? Especially the Moses, Pratt sign, you talk about Homan sign, anything should not be performed because they increase the risk for aggravating the DVT into pulmonary embolism, right? If there's a patient who's having a contraindication for anticoagulation, example like recent history of stroke, I will go with IVC filter, which is called as Greenfield filter. What is the duration of the warfarin? If there's a first episode, it is 3 months. If it's a second episode, it is going to be lifelong, because the probability of developing the third episode of DVT. See, if a patient has first episode, the probability of second episode is 30%. If there's second episode, the probability of third episode is 90%. You cannot take risk, start the DVT for, your warfarin for lifelong. How do you monitor the effect of warfarin? We have a target INR, which is going to be between 2 to 3. INR less than 2, increase the dose of warfarin. INR more than 3, decrease the dose of warfarin. Keep it between that. Okay? So this is in the context of deep vein thrombosis. Now, question number 18, we have already gone through it before. A truck driver presented a dilated tortuous vein of 4 millimeters. More than 3 millimeters, I know it is going to be varicose vein. So, according to SEEP classification, varicose vein is a C2 classification, right? Okay. What is the stage of the clinical classification according to SEEP classification? See, he has not given anything else. There is no eczema, there is no pigmentation, there is no edema, nothing. So it's a simple case of varicose vein. C1 is going to be telangiectasia and reticular vein. This is C2. So 18 is going to be C for Calcutta. It is a C2 disease. We have already discussed it. What do you mean by first episode? First episode DVT का मतलब पहली बार जब पेशेंट को DVT होता है, ठीक है? पेशेंट आया, उसको कभी पहले DVT नहीं होता, पहला एपिसोड DVT है, उसको आप 3 महीने के लिए वार्फरिन दोगे, उसके बाद बंद कर दोगे. लेकिन अगर एक और बार DVT हो गया उसको, तो उसको सेकंड एपिसोड बोलोगे, और सेकंड एपिसोड ऑफ DVT वाले के लिए लाइफ लॉन्ग आपको वार्फरिन चालू रखना है. दैट इज द ऑब्जेक्टिव, दैट इज प्रेजेंट. Question number 19, what do you have? Which of the following is not a part of RTS scoring system? That is a revised trauma score. Now, when you talk about RTS scoring system, it is called as GBR, that is Glasgow Coma Scale, Systolic Blood Pressure and Respiratory Rate. Then you have another scoring system which is called as stress, that is Trauma and Injury Severity Score. The mnemonic for that is going to be RAM. R stands for the components of RTS, that is GCS, Systolic Blood Pressure, Respiratory Rate. A is age and M is mechanism of injury. Another one is what we call it as MES, that is your Mangled Extremity Scoring System. The mnemonic to remember that is ELISA. E is the energy with which the injury is occurred. LI stands for status of limb ischemia. S stands for status of shock. A is the age of presentation, right? So this is what we call it as Mangled Extremity Scoring System. That is going to be MES. Now here asking about your RTS scoring system, which is not the part. We know RTS ka mnemonic was GBR. G is your Glasgow Coma Scale. B is your systolic blood pressure. R is your respiratory rate. GCS, yes. Systolic, yes. Respiratory rate is not the pulse rate. So answer here is C for Calcutta. So question to answer 19 is going to be C for Calcutta. Question number 20. Chalo. Now, when you have a 50-year-old male who is a chronic smoker presented to the hospital with intermittent claudication with both the thighs and the buttock regions on walking about 500 meters, right? Which is the following likely diagnosis? It's a very simple question. They're asking you, they've given you the level of intermittent claudication and they're asking you, sorry guys. They're asking, they told you which muscles are involved in intermittent claudication. They're asking you the level of occlusion, as simple as that. So when you have the occlusional status, you can have the ioto-iliac occlusion, you have the iliac occlusion and the femoro-popliteal occlusion, right? Now, when you talk about the intermittent claudication, so here we'll start with the gluteus. So this claudication is going to be with the gluteus muscle. In an ioto-iliac, it will have a bilateral intermittent claudication. The other two is going to have unilateral. The minute you see bilateral intermittent claudication, I know it is iliac occlusion. Here it will be involvement of gluteus, thigh, calf and ankle. Here gluteal sparing is there. There will be involvement of thigh, calf and ankle. Here it will be both gluteal and thigh sparing. There will be involvement of calf and ankle is present, right? So based upon which muscles are involved, you can now predict that what is the likely component or the level of occlusion. Now here, when you talk about the bypass, it is going to be ioto-bifemoral bypass. Here it is going to be an ioto-femoral bypass. Here it is going to be an iliopopliteal bypass. It is an iliopopliteal bypass. We will use the material Dacron here. Here also Dacron. Here I will use autologous reversed great Cephalus vein. Here I will use an autologous reversed great Cephalus vein will be used, right? So based upon this, you can predict. Now here the question says the patient is having gluteus, that is buttock is involved and thigh is involved, and the patient is having Clonsova hospital intermittent claudication with both. So bilateral is there. So bilateral. So when I say bilateral is ioto-iliac. So it's an arterial disorder involving superficial femoral artery. No, it is arterial disorder involving ioto-iliac involvement. Correct. Not femoral insufficiency, not profunda femoris. So answer here is going to be involvement of ioto-iliac involvement. That is going to be B for Bombay, right? Is going to be B for Bombay. Now that is your question number 20. Now question number 21. Now, according to the asepsis wound score, what is the following are into consideration except? In the asepsis wound score, the mnemonic itself is going to be asepsis. The mnemonic itself is going to be asepsis. A stands for additional treatment required for wound healing. It is your additional treatment required for wound healing. S stands for serous discharge. E stands for presence of erythema. P stands for purulent discharge. S stands for separation of deep tissue. I stands for isolation of organism. And S stands for stay in hospital for more than or equal to 14 days due to wound infection, right? So, which of the following or except Pusha? Okay. Number one, when you look at this wound swab from the side, that is nothing but isolation of organism. Yes, we do it. Serous discharge is considered. Erythema is considered. We don't consider induration. There is no induration. So D is the right option. So 21 is going to be D for Delhi. 21 is going to be D for Delhi. So I've given you two important wound scoring systems that you have. Asepsis we have already discussed. Another one is Southampton wound grading system. 0 is normal healing, 1 is mild erythema, 2 is erythema with other signs of inflammation, 3 is clear or hemoserous discharge, 4 is pus, 5 is severe wound infection or hematoma requiring wound aspiration, or I can say the hematoma aspiration. That is going to be your class 5, right? That is the Southampton wound grading system. Question number 22. When you say question number 22, it's a very straightforward question. A patient comes with long-standing non-pitting edema in the legs. What is the most probable cause? So you're talking about non-pitting edema. Question number 22. See, lymph edema will be non-pitting. If it is an arterial disorder, venous disorder, and coronary artery disease, all of them present to you with pitting edema. So answer is straightforward here. 22 is going to be A for Ahmedabad. Lymphedema will present to you because this is chronic inflammatory response. It is going to have non-pitting edema. Question number 23. It's a spotter. You cannot miss this. There is AV malformation of the scalp in usually the temporal vessels, and this is nothing but your cystoid aneurysm. right? So it's a cirrhoid aneurysm that you can see. That's the spotter that you have. It is given clearly. 41-year-old female presented tortuous swelling over the left side of the scalp and the face, showing in the image given below. Local examination, swelling was pulsatile. On auscultation, bruit was heard. Which of the following is the most likely diagnosis? Cirrhoid aneurysm is basically an AV malformation. It's an AV malformation, or basically it's an AV fistula. It is an AV fistula. Usually it's congenital, but it can be secondary to trauma also. If it is seen on the scalp, it is called a cirrhoid aneurysm. Nothing spectacular about it. Question number 24, we have already discussed this. True statement about intermittent claudication. Now, what is the concept of intermittent claudication is, patient at rest will not have any pain, starts to walk. As the patient starts to walk, the oxygen demand will increase. The blood supply cannot be increased because the vessel is occluded. Patient will have hypoxia, there will be pain. Patient continues to walk with pain, it will become very severe. He stops due to pain. When he stops due to pain, he is going to rest. When he rests, so what is going to happen? The demand of the oxygen by the tissue will decrease. The pain will improve on resting. It will reappear on walking again. Now, it is felt as rest is wrong. Most commonly felt in the calf muscles is correct. Day-to-day distance is variable. Usually when you talk about day-to-day distance is variable, no. Usually it remains consistent. Relieved after getting out of the bed, no. Relieved after resting, so answer here is going to be B for Bombay, right? We have already discussed it in detail, so don't worry about it. Clear? So far, any doubts? Quick feedback. Quick feedback. So far, any doubts? Quick feedback. Okay. Just to give you perspective here, there's Boyd's classification for intermittent claudication. There is Boyd's classification for intermittent claudication. Now, what is this? In the Boyd's classification, we have grade 1. In grade 1, pain appears at start, disappears on walking. Disappears on walking. It is going to be grade 1. Then you have grade 2. In grade 2, patient continues to walk with pain. Patient continues to walk with pain. Then you have grade 3. In grade 3, patient takes rest due to pain. Patient takes rest due to pain, that is grade 3. Grade 4 is going to be rest pain. Grade 4 is going to be rest pain. The grade 4 is going to be rest pain. So, question number 25. What is question number 20? Which of these following is the most likely life-threatening injury that can be identified on breathing component alone? So, when you talk about which of the following is life, first let's take 4 options and see which of the following is life-threatening or not. Cervical spine injury is not life-threatening. Tension pneumothorax, blunt cardiac injury, and tracheal injuries are life-threatening. Now, the option A cannot be the answer. You have to choose between the first 3 ones. Now, tension pneumothorax, blunt cardiac, and tracheal injury, which of the following can be assessed by breathing? With breathing, I think I will be only able to assess the tension pneumothorax, right? Blunt trauma, which is going to be cardiac, it can be pericardial temporate, where you have Beck's triad, right? Here you have the Beck's triad. The Beck's triad is consistent with hypotension, raised JVP, and muffled heart sounds. None of them can be assessed on breathing. So this cannot be the answer also. This is gone, right? So A is gone, C is gone. Now, when you talk about the tracheolaryngeal injury, they present with stridor not on the basis of respiratory component. So this is also gone. So answer here is going to be B for Bombay. It is going to be B for Bombay. Okay. So answer here is going to be B for Bombay. And remember, there's something called as deadly dozen in the thoracic injuries. Deadly dozen means 12 injuries. 6 of them are considered to be immediately life-threatening. The another 6 is potentially life-threatening. For immediately life-threatening, remember the mnemonic as ATP TOM. When I say ATP TOM, A stands for airway obstruction, T stands for tension pneumothorax, P stands for pericardial tamponade, T stands for tracheobronchial injury, O stands for open pneumothorax, M stands for massive hemothorax, right? So these are the conditions which are immediately life-threatening. If you know immediate, you will also know potentially life-threatening. Just remember these two components, right? So that's a question number 25. Question number 26, what do you have? I have a 50-year-old male presented with a routine annual checkup found to have an abdominal aortic aneurysm of 40 millimeters, right? Which of the following is true about the management of this patient? Again, abdominal aortic aneurysm management is very, very important. We'll quickly go ahead, right? Now, whenever we talk about any aneurysm, so any patient comes to you with aneurysm, there are two objectives. Either the patient is symptomatic or incidentally found. Either the patient is going to be symptomatic, either the patient is symptomatic or incidentally found. If the patient is symptomatic, then there is no argument. Here you have to go ahead with repair. You take the patient for repair. Now, if the patient is incidentally found, in these patients, what are we going to do? Incidentally found, we are going to measure aneurysm diameter. We are going to measure the aneurysm sac diameter. Now, once you measure the aneurysmal sac diameter, then we have something called as the critical diameter for the vessel. We will see whether the sac's diameter is more than the critical diameter or whether the sac's diameter is less than that of the critical diameter. If the sac's diameter is more than that of the critical diameter, then you will take the patient for repair. But if it is less than the critical diameter, then you will go ahead with observation and follow-up. We'll go ahead with observation and follow-up. We'll go with observation and follow-up. Now, what is this critical diameter? So, in order to understand the critical diameter, ascending thoracic aorta, descending thoracic aorta, and the abdominal aortic aneurysm. For ascending thoracic aorta, it is 5.5 centimeters. For descending thoracic aorta, it is 6 centimeters. Abdominal aortic aneurysm, again, it is going to be 5.5 centimeters. It is going to be iliac artery is going to be 3.5 centimeters. Femoral artery, popliteal artery, splenic artery, superior mesenteric artery. For all these vessels, it is going to be 2 centimeters, right? So this is the carry-home message that you need to take across here. So these are the critical diameters. Nothing spectacular about it. If you know this, pretty good, great. These are the critical diameters, right? Now, whenever you have the abdominal criteria that we have just discussed it, these are going to be present. Okay. Observation and follow-up also depends upon the presenting vessel's diameter, right? Now talk about the follow-up for abdominal aortic aneurysm. We will see whether it is less than 4.5 centimeters or more than 4.5 centimeters. If it is less than 4.5, I will ask the patient to come back after 1 year. And if it is more than 4.5 but less than 5.5, I'll ask the patient to come back after 6 months, right? Now, after 1 year of assessment, if there is an increase of more than or equal to 10 millimeters, this is called as critical increase, then I will take the patient for repair. In a 6 months follow-up, if there is an increase of more than or equal to 5 millimeters, again it will be called as critical increase. Here also we'll take the patient for repair. So these are the criterias for repair on the either sides, right? So in the question, it was 40 millimeters. 40 millimeters is less than 4 centimeters. If it is less than 4 centimeters, it was asymptomatic. It is going to be observation and follow-up, right? Here you can see it is going to be 40 millimeters. That is less than 4 centimeters. Routine checkup is there. So hence the patient is asymptomatic. So I'd say there is no repair required. Surgery is indicated the aneurysm is more than 55 millimeters is correct. Urgent OT not required. Surgery is no 77. The answer is going to be B for Bombay, right? Now this algorithm is going to be very, very, very important. I've given you the whole objective here. So this aneurysm or the algorithm to manage the entire aneurysm is absolutely important. We have laid down for you. Clear? Okay. So that was the question number 26. 27, we have already seen the question before. A 38-year-old man brought to the emergency department after a stab injury to the lower chest. Presentation had bradycardia and hypotension, okay, usually seen in pneumothorax, right, which did not improve despite of IV fluid administration, right. The chest radiograph shows clear lung fields, okay, so there is no pneumothorax also. What is the next step in the management? Now, because the patient has presented to you with injury, and here there is some hemodynamic instability, they're asking what is the next step. The next step is going to be E-fast, that is your extended fast. I'll not put you because there's no evidence of pneumothorax. CCT will only be done if the patient is stable. So when the patient is not stable, I cannot do it. So best option here is going to be E-fast, that is your extended fast. Question number 28. A patient underwent surgery for breast carcinoma. She now presents with painless swelling involving arms as shown in the image. What is the most likely diagnosis? Now see, I can simply go ahead and say the answer here is lymphedema. It is not lymphangiosarcoma. For venous thrombosis, it should be associated pain. Cellulitis would be redness, pain, and fever. So none of them are mentioned. So I'm going to rule out the venous thrombosis or cellulitis. Now the question is lymphedema or lymphangiosarcoma. Now, patient underwent modified radical mastectomy. Now, post modified radical mastectomy, if within 1 year, if there is swollen upper limb, it is secondary to lymphedema. In fact, the most common cause for secondary lymphedema of the upper limb is your breast surgery. The most common cause for secondary lymphedema, in upper limb is modified radical mastectomy. On the other hand, after MRM, you wait 10 to 15 years. After 10 to 15 years, if there is same-sided ipsilateral lymphedema with bluish discoloration of the skin, then the answer is going to be lymphangiosarcoma. This is called as the lymphangiosarcoma. This condition is what we call it as a Stewart-Travis syndrome. This is your Stewart-Travis syndrome, right? Now, the most important thing for Stewart-Travis syndrome, it has to be a wait period of 10 to 15 years. Within 1 year, it is going to be lymphedema. And after 10 to 15 years, it is going to be Stewart-Travis syndrome. So here, because they have not mentioned the time period, we're saying immediate post-op, the answer is going to be lymphedema. For lymphangiosarcoma Stewart-Travis syndrome, the management is going to be 4-quarter amputation. Associated with very poor prognosis. In 4-quarter amputation, what do you remove? Same-sided clavicle, ipsilateral clavicle. ipsilateral scapula. We remove the same ipsilateral arm. The entire arm, clavicle and the scapula of the same side are going to be removed. So this is with respect to Stewart-Travis syndrome. Question number 29. A patient after a road traffic accident presented to you pain in the abdomen. The resident examined the child and found that the vitals were stable. Okay, tenderness was present in the left lumbar region. What is the the best investigation of choice, right? So here for all traumatic conditions of the abdomen with hemodynamic stability, the answer is going to be CCT abdomen. We've already discussed it before, nothing spectacular about it, right? So answer here is going to be A for Ahmedabad. Question number 30. A patient presented to you with a motorcycle road traffic accident. There was no pain or injury. Examination showed blood at the tip of the urethral meatus. What is your next step in the management? So whenever you have blood at the tip of the urethral meatus, you have to assume there is a urethral injury. Now there are two sets of urethral injury. You have the anterior and the posterior urethral injury. When you have the anterior urethral injury, we're talking about the penile urethra as well as the bulbar urethra. Here we are talking about the prostatic urethra with the membranous urethra. The most common site here is going to be the bulbar urethra, and here it is going to be membranous urethra. So look at the mechanism. Anterolateral injury is usually against fall over a projecting object, hit or blow onto the perineum. Posterior is pelvic fractures in a road traffic accident. Clinical features will be presence of blood at urethral meatus. Blood at urethral meatus, which is going to be for both of them. Along with that, there will be presence of perineal hematoma in anterior urethral injury. Perineal hematoma, an inability to pass urine. An inability to pass urine. For posterior urethral injury, there is again blood at urethral meatus. There is blood at the urethral meatus. Then there is pelvic hematoma. There is presence of pelvic hematoma and again inability to pass urine. Again there is inability to pass urine. There is again inability to pass urine. Investigation for both of them is going to be RGU. Management for partial injury. So in the partial injury, you will not see the contrast moving further completely. In the partial injury, the contrast will go into the bladder. In a complete injury, the contrast will not reach to the bladder. For partial injury, I can go with Foley's catheterization. For complete, you have to go with suprapubic cystostomy. Now, I've given you two images. Image number 1, image number 2. Out of these two, which is RGU and which is MCU? Also, tell me which is RGU. 1 or 2, which is RGU? 1 or 2, which is RGU? That is retrograde ureterogram. MCU is maturating cystourethrogram. Out of 1 or 2, see, here bladder is full, here bladder is not filled, right? So how do you differentiate it? If the bladder is full, it is your maturating cystourethrogram. So this is your MCU. If the bladder is empty, this is your retrograde ureterogram. So this is your RGU, right? If the bladder is filled, it is MCU, maturating cystourethrogram. If the bladder is not completely filled, it is a retrograde ureterogram. As simple as that. Okay? So RGU is your image number 2. The question is, what is your next step? Now, our patient presents to you this bladder urethral meatus. Actually, the next is going to be to evaluate the extent of the injury will be the right answer, right? Now, here I will not go with catheterization directly. If there's only blood at meatus and there's nothing else, I'll wait and watch. There's no need for nephrogram, no need for suprapubic cystostomy. See, in order to make a decision of Foley's or suprapubic, RGU has to be done. Without doing an RGU, you cannot make a decision. So here we'll wait and watch. If the patient is able to pass the urine without any problem, we don't need to do anything. If the patient has inability to pass urine, then you will go for intervention. Here, there is no mention of inability to pass urine. So hence, you can wait and watch, right? So wait and watch only if patient is able to pass urine. That's a question number 30. Question number 31, we have already discussed it in the trauma part. A patient after a road traffic accident presents with subcutaneous emphysema. Okay, on auscultation, there is no air entry on the right side. Vitals are unstable. What is your next immediate step in the management? Right. The next immediate step in the management, what it says, it is E faster. Okay. Would you like to go ahead with insertion of wide bore needle in the fifth intercostal space, wide bore needle to decompress and IV fluids, intubation and positive pressure ventilation, and E-fast? They're asking about, see, this is a patient following a road traffic accident present with subcutaneous emphysema. On auscultation, there's no air entry on the right side, so there's a pneumothorax, right? So probably tension pneumothorax you're talking about. So immediately you have to decompress it. So insert a wide bore needle in the fifth intercostal space makes sense. Okay? So that's your next immediate step. So answer here is going to be A for M double. Question number 32. Now what do you have? In a question number 32, I have a 70-year-old female present with pain in the thigh during walking. Investigation reveals the finding that you can see here. Okay, what will be the best surgical management? We already discussed. No. So here you can see on one side it is contrast is flowing, the other side is not. So it is not aortoiliac, it is your iliac occlusion. For iliac occlusion, we have discussed it. No, it is going to be an aortofemoral bypass. So here it is going to be an aortofemoral bypass. So here the diagnosis is it is an iliac occlusion. This is your iliac occlusion. So aortofemoral bypass. So answer here for 32 is going to be an aortofemoral bypass. We've already discussed in the previous question also. Give me a second. Chalo. Question number 33, SEEP classification we've already seen. This is varicose vein. Okay. So in the varicose vein, what will be the classification? They've asked you, according to SEEP classification, what will be C stage of this disease, right? So when you ask for the C stage of the disease, now, okay. So what is C1? C1 is going to be telangiectasia or reticular vein. And the image is of varicose vein. This is for varicose vein. So D cannot be answered. C4A is going to be, what is C4A? It is going to be pigmentation. So there is no evidence of pigmentation, so it cannot be, right? Now, what is C2A and what is C2S? Now, yeah, so you need to be very precise about it. It's a C2 disease, right? So what is C2A and C2S? It is now on the lateral side. Medial side is going to be Cephalus, great Cephalus nerve. Great Cephalus vein. Lateral side is going to be short Cephalus, right? So it is going to be your lateral side, which is present here. So lateral side is going to be your C2A. Medial side is going to be C2S, right? That's the abbreviation that is given. So it is C2A is going to be the answer. 34, a very, very important question that you have. A patient presented with blunt trauma to the abdomen. On evaluating, liver injury was noticed. The primary repair was done. Coagulation function was monitored intraoperatively using this method. What is this method? This is what we call it as TEG. TEG stands for thromboelastography. Very, very important, right? Now, this is the normal TEG. So if you see this curve, this is the normal TEG. How do you evaluate? Any idea? I think a lot of people would have spoken about TEG already. Thromboelastography, there are three things that you're going to measure. Number one, this is how the graph is going to look like. The first thing is called as the R time, that is called as the reaction time. Normal is going to be 5 to 10 times, which is R time is dependent upon the clotting factors and the anticoagulants. Then you have something called as K, that is the kinetics. That is from the end of the R time, to the midpoint of its aggravation. This is what we call it as the K, which is kinetics. Now, basically it depends upon the fibrinogen and everything, right? Then there are two more points that you need to assess. So if you take, this is the midpoint which is going to be present here, right? This angle that you can see between the portion, between the midline and this angle, this is what we call it as the alpha angle. This is what we call it as the alpha angle. The normal alpha angle is going to be 50 to 70 degrees. Now, this is also based upon the fibrinogen and everything, right? So, whenever there's decrease in fibrinogen, this angle will become acute. Then there is something called as MA max. MA max is, you can see, whichever the widest portion you take it. This widest portion is what we call it as the MA max. This is what we call it as MA max. When I say MA max, that is the maximum amplitude that is present. The MA max, again, it basically denotes the, if I have to put it this way, it basically denotes the platelet factors. It is going to be platelet. Then the last one is the lysis. This is the end where it is breaking down. This is what we call it as lysis. Because LY30, all these are there. So basically, you measure R time, K is kinetics, alpha angle, and MA max, right? So this is how you measure across it. They have their values. Remember, the normal R time is 5 to 10. The normal kinetics, which we say, it's basically if the K is increasing or decreasing, that you have to see. That depends upon. But take a interpretation, no, it is going to be a little bit more complex. It will take, I mean, we have a separate lecture on it. But thromboelastography gives you dynamic changes that are present. From the point the clot starts to form till it starts picking it up, this period is called as R time, which is the reaction time. This depends upon the clotting factors and anticoagulants. If there's a deficiency of that, this will become shorter. Then from here, as the clotting picks up, the midpoint of its maximum amplitude is called as the K, which is called as kinetics, right? Now the K also depends upon, or I can say the kinetics depends upon the fibrinogen basically. It depends upon the fibrinogen, right? If the K increases, then you have to give cryoprecipitates, right? Then you have the alpha angle. This is the angle between the objective and the component which is present from the midpoint. Normal alpha angle is 50 to 70 degrees. If the alpha angle becomes narrower, then I can say it has deficiency of fibrinogen that is present here. MA max is the maximum amplitude. Again, it depends upon the platelet components. Okay? I don't think nobody is going to ask you in a very great detail about it, but if you know these components are more than enough to assess thromboelastography. Question number 35. Our child had a history of stab injury on the anterior abdominal wall. We have already discussed it. And the image is given below. Child is hemodynamically stable. What will be the next course of the treatment? Stab injury, hemodynamically stable. What will you do? We have already discussed it. So here you can see the omentum is popping out. So there is a peritoneal breach. For every patient of peritoneal breach, I am not going to go with observation, not with fluids, not wait and watch. I have to take the patient for exploratory laparotomy. You can see the omentum is popping out. See what pops out. That becomes the important objective. Question number 36. Which of the following is most likely to be seen due to a rupture of saccular aneurysm? Now, when you talk about the most common site of aneurysm in the body is Berry's aneurysm, which is going to be in the subarachnoid space. And obviously, subarachnoid hemorrhage will present to you because of ruptured Berry's aneurysm. So here it cannot be subdural, not intracerebral, not hydrocephalus. It is going to be subarachnoid hemorrhage. Ruptured Berry's aneurysm is in the subarachnoid space. So answer here is subarachnoid hemorrhage. Question number 37. The patient of sudden onset of right leg pain on investigation was done, obtained. What is the investigation? Now, it cannot be a digital subtraction assay DSA because this is the image of DSA where the vessels are clearly visualized. Okay? So, obviously, that cannot be the answer. It looks like an ultrasound Doppler. Yes, the answer is USG Doppler. MR angiography, there is not an MRI image. Plethysmography, I have given you the image where you measure the lung volumes and all. So this is not the answer. So answer here is going to be B for Bombay. It's a very clear-cut objectives. This is your DSA, this is your plethysmography, MRI images, you know how to interpret it. This is your Doppler ultrasound. Question number 38. Calculate the percentage of the burn in a preschool child shown in the image. When I say preschool child, obviously less than 14 years of age, right? So here, in a child, when you talk about it, the head and neck. In a child, the head and neck is going to be accounting for. So when you talk about the entire birth, see, we have to differentiate between the adult and the child. Clear, guys? Right? In the child, the head and neck is going to account for 18%. The upper limb is going to be 9%, which is going to present the anterior trunk, and the posterior trunk is going to be 18%. The lower limb is 14%. There is no perineum that exists here, right? That is the objective that is present, right? So here, what is burnt? In the upper limb, only half is burnt. So it is out of 9%, it is going to be 4.5%. Okay. So upper limb में half गया ना. So this is going to be involved. So 4.5% is involved. Then the anterior trunk, which is 18%, is involved. Then you say lower limb ka upper half. So this is going to be 7%, this is going to be 7%. So 7 plus 7 is going to be 14%. So I'm saying 7% plus 7%, correct? No. So 7, 7, 18 I'm taking, this I'm taking 4.5, right? So this is the entire objective. So how much it is going to be? So 18 plus 14. 18 plus 14 is how much? 28, 32. 32 plus 4, 36.5%. This is what the value I got. So 36.5 is going to be between 35 to 40%, right? So answer here for question number 38 is going to be C for Calcutta. Clear? So it is around 36.5%. Now here, the upper limb mein only half is gone. The anterior trunk is gone. The half of the thighs are gone. Okay, the upper half of the lower limb. 7, 7, 4.5, 18. I'm only correct, no? 18 plus 7, 25, 30 to 36.5, correct. Question number 39. Now, this is a patient presented with tender pulsatile mass as shown in the image. What is the next step in the investigation? So when you have a pulsatile, it's a vascular mass. Never go with needle aspiration. Then it cannot be a percutaneous management. It could be cricoid, or I can say the carotid aneurysms also. So again, don't do it. No need for antibiotics. The answer is going to be ultrasound first and then do a CT angiography. So they're asking the next. Next is going to be ultrasound. Question number 40. I have a male patient with impotency and bilateral resting pain. Okay. So when you have male impotency, there is male impotency by bilateral intermittent claudication or lower limb pain. This is what we call it as the Lehrer syndrome. Lehrer syndrome occurs when there is an ioto-iliac occlusion. When there is an ioto-iliac occlusion. When there is an ioto-iliac occlusion, right? So at what level the pathology is there? We have already discussed it. The level of pathology here is going to be ioto-iliac bifurcation. It's a classical case of Lehrer syndrome, right? We're going to question number 41. Identify the fluid shown below. So what do you have? I have sodium of 131. Sodium of 131. I have potassium of 5.4. I have calcium of 2. I have chloride of 112. I have lactate of 29. And this can only be seen in Ringer lactate solution. This is the composition of Ringer lactate. So answer here is going to be B for Bombay. It is going to be B for Bombay. When look at the other ones on the sake of comparison, this is the difference that you can see here. So Ringer lactate or Hartmann's are almost same. The only thing that is going to be differentiated is little bit of parameters. Hartmann's Potassium is 5, ringer is 4.5, calcium is 2, it is 2.7 here, chloride is 111, it is 109, lactate is almost same, there is no other components are present. Normal saline is going to be sodium and chloride as 154, then you have plasma light that is present. In plasma light, you can see there is present of sodium, there is potassium that is present, and the chloride that exists, there is no calcium. Hemosil consists of sodium is there, potassium is there, calcium is there, chloride is there. Hepastase does not consider any of these following components, is only complete of the colloid that is going to be present. And then you have dextrose, which is going to be 30 of sodium, 30 of potassium, and glucose of 140. Remember, in hepastase, that is hydroxyethyl starch is present, right? So these are the components that are to be remembered, right? So this table is important with respect to the following discussion. This we have already discussed it about the pressure sore, right? Image is shown below. What is the stage of this pressure sore? You can see underlying muscle is involved. Answer is going to be stage 4. Question number 43. A patient was found to have a deep ulcer in the heel as depicted below. What is the association? Now, such ulcers which are with the slough, they are usually diabetic foot ulcers, right? So, for these patients, for diabetic foot ulcers, what do you have? Decreased pulsation of dorsalis pedis. No, diabetic foot ulcers because of microangiopathy. So, there will be loss of sensation. So, decreased foot sensation, not Trendelenburg, no passive movements on calf, nothing. Answer here is going to be decreased foot sensations. Question number 44, what do you have? In question number 44, regarding the frostbite. Now, we talk about frostbite. What are the correct statements? The frostbite is because of intracellular ice crystallization and microvascular occlusion, usually involving finger, toes, and ears. When we talk about first degree, there is only hyperemia and edema without any skin necrosis. In second degree, there will be presence of superficial vesicle, which are going to be clear or milky. In third degree, there will be hemorrhagic bullae. In fourth degree, there will be presence of gangrene. That is the level or the degree of the frostbite. First is going to be rapid rewarming, then your splinting and elevation. TT has to be given. Early amputation is not recommendation because it is going to improve, and the indication of amputation only if the gangrene exists. Now come back here. Amputation in severe cases, yes, is correct. Antibiotic analgesia are not used. Rewarming is not done, is wrong. We have to do it. Clean and dry the area. So when you talk about in terms of we are looking for correct statements, right? So in question number 44, which are the correct statements that you have? First statement is correct. Antibiotic analgesia are used. Clean and dry the area is correct. So here only 1 and 4 is correct. Answer A for Ahmedabad. Question number 45. In question number 45, they're asking you which of the following regarding the psoas abscess is correct. Now, any abscess will have a fluctuant swelling that can be elicited in thigh region is correct. Pot spine can present a psoas abscess is also correct. Pain occurs during extension of the hip, absolutely correct. Caused by hematogenous route of spread of TB is one of the most common, that is in immunocompromised, correct. All 4 statements are correct in psoas abscess. Question number 46. What do you have in question number 46? Patient was admitted with a history of knife injury over his arm. The radial and the ulnar pulse were not felt in this patient, and it was found that the brachial artery was having a longitudinal split. So when you take this is the blood vessel, he's talking about there is a longitudinal split which is present. This is the orientation of the split that is present, right? So what would you like to do? Now here ideal management, say I'm not going to use prosthesis. If you ligate, there will be no vasculature, the arm will go away. Primary closure with saphenous, see if you close it, it becomes more narrower. I cannot do a primary closure, so I have to put the saphenous vein graft only. So answer here is going to be A for Ahmedabad. Question number 47. I have a patient with a tibial fracture 1 month ago. The cast was removed. Few ecchymosis were observed. Few days he came back with the pain when lifting with his great toe, and there was also decreased sensation of the first web space. Both the posterior tibial and the dorsalis pedis artery pulsations were felt. What is the next step in the management? Now here patient is going into compartment syndrome. So you have to evaluate for compartment syndrome. How do you evaluate? It is not for DIC, no need for venous Doppler. Here we are not talking about venous, it is not about DVT. Yes, I would like to measure the compartment pressure, admit and give analysis and no. So you have to see whether the patient is developing compartment syndrome or not. Measure the compartment pressure more than 30, then you have to do a prophylactic fasciotomy. Question number 48. After a daycare procedure, which of the following should be the most common cause? See, most common cause for post-operative admission. When you talk about the most common cause for post-operative admission is going to be bleeding, right? But if I ask you most common complication, the nausea and vomiting is the most common post-operative complication in a daycare surgery. The most common post-operative complication in a daycare surgery is nausea, vomiting, but the reason for readmission is always bleeding. Question number 49, what does triage mean? We have asked you again and again. Triage basically means to sort things out. It is to distribute, and this is done on the basis of outcome, not on the basis of severity. So 49 is going to be B for Bombay. Last one, 50, what is the size of the cannula? It is the green cannula. Green is going to be 18 gauge. 18 gauge at 90 ml per minute. Answer is going to be D for Delhi. Quickly, if you talk about all the color codes of the cannula that you have, when you start from down to bottom, we say the core of the earth is made up of lava. Lava is going to be orange in color, right? Then you have soil which is present on top. The soil is going to be gray in color. The soil is going to be gray in color. Then you have green trees which are going to be present. Then you have pink flowers. Then you have the blue sky. Then you have the yellow sun. And then you have the violet universe. If you don't believe the universe, I can just put some stars for you so that you believe it. So the first one that you have is orange, which is going to be 14 gauge at a 240 ml per minute. Then you have gray colored cannula, which is going to be 16 gauge at 180 ml per minute. Then you have green colored cannula, which is 18 gauge at 90 ml per minute. Then you have pink colored cannula, which is going to be 20 gauge at 60 to 65 ml per minute. Then you have blue colored cannula, which is 22 gauge at 30 to 35 ml per minute. Then you have yellow colored cannula. Yellow is going to be 24 gauge at a flow rate of 20 ml per minute. The last one that you have is violet, which is 26 gauge at a flow rate of 12 ml per minute. At a flow rate of 12 ml per minute, right? So this is all the color codes and the flow rates that are going to be present, right? So this is all in all with respect to your first 50 questions in general surgery, right? So we try to keep it crisp, we try to revise it to the point, and this is how you're going to approach in the exam also. This is how you need to assess a question, look at the options, derive the answers from there, and then move it forward, right? So the other two sets of the questions will be done on the app, which is going to be day after tomorrow. So you have two more sets day after tomorrow. That is going to be on Monday and Tuesday. We have two more sessions of TnD, right? Thank you so much for joining. If you have any questions, any queries, do reach out. You can follow me on my Instagram page as well as on the Telegram for the notes as well. This is the surgery guy. Okay, I should have introduced myself. I forgot. My name is Dr. Sandeep Sir. Any questions, any queries, do reach out, right? Thank you so much for joining. Take care. Bye.